Okay, we are going to go ahead and get started here at, what time is it? 9:30 exactly. We've got some folks I know that from our council that are on break, I believe, already. Hard to believe it's spring break when you look outside. So, okay, everyone, we're going to go ahead and get started. I will call just to see who's here. I think I've got most people, but go ahead and do that. Kelly.
Good morning.
Talee.
Here.
Clark. Lexi Westerfield. Kim Dodson.
She is here, but
I know I did see Kim.
She went to get Lexi.
she's here, but not.
Oh, did she? Oh,
Yes,
okay,
she
okay.
mentioned to me.
Oh, gotcha. Okay. Melissa Keys.
Here.
Derek Nord.
Yep. Sorry.
Oh, sorry. Ann Titus
Yeah.
here. Dr. Jim Wiltz.
Yes.
Katie Stafford Cunningham.
Brandy for Katie.
My pen is not working, of course. Laura Fife.
Here.
Kate Barrow. Lisa Paddock.
Yes.
Carrie Lee.
Here.
And Kim Hahn.
Here.
Okay, great. All right, we'll go ahead and we'll have a couple folks joining us here and there. Okay, I am going to share a quick video. This will be very timely for Christina Commons. She'll love seeing her face, I'm sure, on this video publicly. But as you guys know, we did some revamping of our website, which coincided with BBA joining, formerly Division of Aging, joining over and merging with DDARS. So now DDARS. So we did some work on our website, which is great. Hopefully you guys have checked it out. With that, we also worked with a partner to create some videos, just really explaining what each of the bureau is, talking to some family members. And today we have Christina Commons presenting from the Bureau of Child Development Services. So I thought we would share the video that is on our website. And again, I know she will probably get red when she sees her face on the screen. So hold on one second as I pull this up to share. Hopefully you can hear it. He was working with me before, so cross your fingers there. I will make it.
Colin was born with trisomy 21, also known as Down syndrome. Some of the challenges that Colin faces is that he has low muscle tone. So we do physical therapy to strengthen his muscles. And then also he has cognitive delays. And so we work with speech to help develop his language skills. But I've been so pleasantly surprised. He has gained so many new skills in such a short period of time. I first heard about BCDS and their services through Colin's developmental therapist, who we see through First Steps. The experience that Colin has had through his therapy has been wonderful. His therapist, Alicia, Colin lights up every time he sees her. He adores his time with her, and he is making huge gains. We've been just so pleased to see the progress that he's been making every week that they spend together. It's been great.
BCDS supports infants and toddlers with developmental delays and disabilities and their families. So these are Hoosier families who have an infant or toddler who has a developmental disability based on diagnosis or is just demonstrating a developmental delay.
So I started taking him outside of the home, as a little baby to these therapies and thinking like, oh my gosh, these are, so many doctor's appointments, so many therapies. So when First Steps started and his therapist would see him at home, I think it was just not only easier on everybody, but brought in a level of comfort to have the therapy at home for Colin.
Oftentimes families don't know how to play with their children, how to help them grow and learn. So we have professionals that come in and coach families, teach them therapeutic strategies to help their children through their daily routines and activities that help promote that development and help them achieve goals that their families have set for them.
before I get back to the Christina. Yeah, I know you wanted to. It was a really good video though, and we had. a
You
great
did
partner.
good. You did really good. You should be proud of yourself.
Oh,
That's kind of you.
all right, so with that, we're gonna jump right off. When we start every meeting, as you guys know, officially, all people are empowered to live, love, work, learn, play, and pursue their dreams. And this is our, if you guys haven't seen, our new logos that we're really proud of and love. And agenda today, again, Christina will share some updates from DCDS, and then Holly will share some information related to beats for the rest of the time together. We'll take a quick break in between. Okay, Christina, I'll be your Vanna for your slides.
Awesome, I couldn't have asked for a better slide. I do need to apologize to everyone that you just got your slides this morning. That is my fault. But excited to be here and to share about the Bureau of Child Development Services and what we're doing in that bureau. We do oversee the First Steps program for the state of Indiana. As you heard in that video, we serve infants and toddlers age 0 to 3 years old who have developmental delays or diagnosed disabilities and their families. What you're seeing here on this slide is data on the total number of children served by county year to date. So July 1st through, I think the data for this was through January 31st. And then next to that is the map, which is the percent of children that we're serving that are 250% or below poverty level. We continue to serve a very large number of those families. We know that developmental delay is unfortunately tied to poverty, and we feel like we can make a huge difference in the lives of these families. Next slide, Jessica.
Yeah, I'm trying to take notes at the same time.
That's okay.
It's not working, okay. Sorry.
All right, I know that there is a lot on this slide. So we'll give you a minute to look at it. I hope that you can pull it up as well. We added a new graph to this infographic. Well, and let me start over. Just to level set, we have 9 local regional offices across the state that deliver service coordination and do evaluations for eligibility for the First Steps program. We have 43 provider agencies that deliver occupational, physical, developmental, and speech therapies. Some of those agencies also have additional services such as nutrition, social work, etc. I have one agency that's trying to enroll a nurse. So that's exciting. We have 100 independent providers, and those are those services such as nutrition, social work, psychology, audiology, ophthalmology, and interpreter services. We have been enrolling more and more audiologists over the past year, which I think is exciting to have access to those services closer to where families live, so they're not having to drive as far. And we do, as we'll talk about, receive probably over 33,000 referrals annually. That number has continued to grow. But in that top corner with the bar graph there, what's cut off is it says referral trends by quarter per calendar year. So the navy blue is for calendar year 2023. The teal is 2024. The yellow is 2025. Seeing this on the screen, I will change the yellow to another color moving forward, so I apologize for that. And really what we're showing here is just those referral trends. And I have another slide next, we'll get into it, that will show this in a much larger visual for you. But really it seems that January, February, and then there's a dip, right? And that seems to happen year over year. And then we're going to keep monitoring this, because what we're hearing from at the local level is that our referrals are down. And by looking at this, it seems that referrals do go down during those quarters, and that's the quarter that we're in. And we should see in Q1 of this next calendar year, 2026, hopefully those referrals are back up to where they saw those previously. So we're digging into this. We're trying to research why we might be seeing that downward trajectory in referrals. Is it that we tend to go down during those quarters every year, or is it something that we really need to be digging in on and thinking about how are we finding infants and toddlers and their families who would benefit from our program? And then the last, if you go down a couple from the referral data underneath number of family visits, we did 438,256 family visits from July through January. Our therapists are working really hard with those families that we're serving. And we're getting in home and community-based settings. The exit data at the bottom is a little bit hard for you to see because it's so far away. And I just want to draw your attention that the top line there, the teal and the blue combined, is the total number of kids exiting. The teal represents those children who are exiting before they ever get to an IFSP. And we're going to talk about that a little bit later in today's presentation. And really trying to dig into how many kids move from referral to evaluation to IFSP. And is there data points in there that we need to really review to maybe retain more of those families between referral and evaluation? Exciting is that we have 3,489 children transitioning from early intervention to early childhood special education. And our service coordinators are supporting that transition with the schools. Children, we had 1,933 children who exited with outcomes met. That's obviously our goal, is that we want to catch children early, work with their families, assist them in that skill development, and then they reach their outcomes met, and they don't need that additional special education services. But if they do, it's there. And then we're also looking at the data about parents who withdraw their children prior to their outcomes met. That's something that we really want to review, and we're working with our interagency coordinating council on our family outcomes survey to identify additional questions that we might be asking all families who exit if their child all children who have exited, their parents do receive a survey. So there might be some additional questions that we could kind of dig in a little bit more there. Do we need to do additional training with our providers and so forth? So we had 1,123 children exit by their parent withdrawing them from the program.
Christina, do you know if they're seeking other services? Like why they're withdrawing? Like if they're
I
going
think
to
that's-
DDA or something like
I think
that?
that's where we need to add that question to the survey. It may be that, and there's an opportunity as well in our data system to refine how we are collecting that exit data. So our service coordinators and SPOs go into that data system and enter the reason for exit, but it's very surface level. It is withdrew by parent, right? So it doesn't go a step further to ask, but why? So that's something that we're looking at doing. Okay, next slide, Jessica. So here is that graph that was in that top corner to kind of really give you an idea of what I was talking about there. It's a little better visual here. But as you can see, kind of in that 2025, it does kind of slope down. So we're watching 2026 very closely to see if it comes back at least to the Q3 level there at 8250. 50. And based on trends, that seems to be where we'll end at the end of this month. But again, we're watching that. Are there any questions regarding that data?
These quarters are on state fiscal year, federal?
Those
fiscal
quarters
year?
are calendar year.
Calendar
We
year.
can, we're working to switch it, but that's what that's what my data manager pulled. And I wasn't gonna ask her to pull it again. So that's what we have here, but I think it's a little bit more nuanced to intermingle the calendar year, so we'll get there. Thank you for that question. Okay, the next slide is exciting. We haven't done this. You are seeing this data hot off the presses. So this is something that we've been talking about, wanting to really pull from our data system now that we have a very competent data manager and who has access to this data, and that we want to really kind of dig in. As you can see, only 55% of our referrals made it to evaluation. So large. I was shocked by that number. And so now we need to figure out, well, what are those exit reasons that we have there? Are we losing family contact with those families? Is there a way that we could adjust our referral process to ensure that there's maybe a warm handoff, that physicians aren't just handing a phone number to a parent, or that they're calling together, that they're putting our phone number into their cell phone when they're leaving that physician's office. Sometimes families just don't answer the phone.
Do most of your referrals come from physicians?
Oh, they
or-
do. If we go back a couple slides on the infographic, it will show our referral sources. We get 62% of our referrals are from the medical space. And then next would be parent referral are the highest.
So you have the referrals that are broken down by quarter. I'm just curious with that or not quite half of the referrals don't end up in evaluations. Does that differ by quarter, or is that?
That's a great question. We have not, we have July 1 through December 31st here.
Yeah, my apologies. You just came up with these
we
data
just
right now,
pulled
so
it, this week. It is really hot off the presses. So we'll get to, I think we want to definitely dig in and see, are there trends where this changes? Or is it consistently, no, about 50% never make it to evaluation? So, and then again, why? And is it that we never make contact? We are a voluntary program. It's not required to participate. And so some families, this just might not be the best time. We do have a number of children who are referred multiple times. And then we could probably look at how many children didn't get an IFSP or eventually got an IFSP, and how many referrals did they have in our system before they got that IFSP. But I have there are probably a large number of those families that just aren't ready for us.
What is an IFSP?
That is a terrific question, and I'm sorry I'm using an acronym. It's an Individualized Family Service Plan.
Thank you.
You're welcome.
Are you using the new evaluation tool that?
We are not. We use a tool called the AEPS. It looks at physical development, adaptive development, cognition, social communication, and social development of all children. And we track child outcomes. We do that initial evaluation, and then we do our therapists are doing it again when a child is leaving the program, so we can track, did we make significant progress in the program.
Is that because the new tool isn't appropriate for this age group, or is it just, I mean, we've talked about using it over all, everywhere, right? That's going to be used on all the.
I just haven't had a chance to really dig into that tool to see if it would meet our eligibility requirements. If it does, it would not be a bad idea to align ourselves with what's being used. It's just, I haven't had a chance to really look at NRA?
I say I couldn't remember.
NRI.
Sure if that was right, NRI, yeah.
And if I may, the first step is taking it across the HCBS, the waivers, essentially, and need services. But that was a great question.
And it's something that I thought about as Holly has talked about changing that tool. We're currently using the second edition of our tool. There is a third edition out, but they haven't created percent delay or standard deviations for that version, so we haven't changed or switched. It's my understanding that Brooks is working on that, and I don't know enough about the tool that Beats is using to know if it would produce those types of results for us.
Do you know about how long it takes from referral to evaluation?
I don't have, I would say probably 10 to 30 days, depending upon the cluster and the number of referrals that they've received during that time frame, the number of annual evaluations that they also have to complete during that time. It hurts me to say 30 days, just a month in the life of an infant or a toddler is an eternity. But we are meeting our 45-day timeline that the statute requires to have a child who's referred have an IFSP in place by the 45th day. You want to go back to the funnel diagram?
Okay. Remind me, was this one?
No, the next one. Nope. One back.
Oh, one back. This one?
Oh, apparently your TV is
Close. Okay.
that one.
That one, sorry, it was like kind of a while.
So while we did lose a large percentage of children from referral to evaluation, the number of children who are eligible who reach that evaluation is 87.4% of those children who are evaluated are eligible, demonstrate eligibility. And then of those 7,647 children that were found eligible, we wrote 7,080 IFSPs. So 92.6% of those eligible children did have an IFSP in place. Again, the program is voluntary. Parents have any number of reasons for why they don't choose to write a plan with us. Sometimes children who do demonstrate eligibility, this is going to sound strange, don't actually need the intensive services of First Steps. They need to be connected with other community resources and opportunities to promote their child's development. Sometimes children start walking during evaluations. I've seen that happen before. They start learning new skills. Parents feel more comfortable and confident when they have a professional showing them what to do, and they just choose not to move forward. And sometimes our evaluation tool it's not perfect. None of them are, and we'll sometimes say this child's eligible because they're not feeding themselves with a spoon. They may be showing a delay in their adaptive skills based on culture or family preference. And so those children don't necessarily need intervention. Any questions regarding this? Any suggestions for how I might update it or change it other than digging into some of those questions?
Do you also track language differences of who's referred?
We do. And
Is there a higher rate of parents withdrawing or participating due to language barriers?
That I will write that down as one of the data points to look at based on exit. Okay. The thing that we are working on, we're doing data lunch and learns with our local SPOs, our systems point of entry, and our agencies and our local planning coordinating councils who provide data to their communities. And the first thing that we're looking at is language, and have some some theories that people are actually not putting that in our system accurately. And that families are being asked a question in hopes that their child will speak English. And so the primary language of their child is going to be English, and that's what's entered into our system rather than what is the primary language of the home. And so there's an opportunity for retraining and data entry support. So we'll be digging in on that. And next time I come, I'll be happy to give you an update on what the results was from looking at that data and thinking about it.
And I guess to piggyback off that, what language support is available to families that are participating in First Steps?
So we will provide ASL, and then we do have foreign language interpreters.
And is that for all services or just when you're meeting like with their service coordinator? So like if they have PT, OT speech coming to the home?
That's a great question. We federally are required to provide that during evaluation and IFSP meetings. So when they're meeting with their service coordinator and their evaluation team. But we do have some interpreter services that are happening during their ongoing services as well. For instance, we have a family on the in Terre Haute whose child has some significant medical needs and they speak a different language. And so we've made sure that they had an interpreter for those services because it wasn't safe if they didn't. And so we're trying to make those accessible. But finding interpreters and having them is very difficult to do. So we are meeting the requirement and we're trying to go beyond that.
Just a question, and I'm sorry, it's a little maybe delayed from the prior conversation. The referral, the drop of 45% from referral to evaluation, what are your thoughts on that? And I don't mean like reflect that, like what do you think's happening there?
I think that some families don't know why they were referred. They don't know who we are, and so they don't answer their phone when we call. And so then they're waiting until they go back to whoever referred them and they say, did First Steps get in contact with you? And they'll say, no, they never called me.
Yeah.
And then another referral is made. But honestly, we have to dig into that data a little bit further to really understand why.
So the people, a lot of those referrals are coming from, let's just say a provider, medical provider or something directly to First Steps. It's not the family member necessarily doing the connecting then.
Yeah,
like, hey, you should connect with First Steps. Here's their information. You call. I would imagine that you get a lot. Okay. Anyway, that's helpful.
No, that's another, I'll write that down as the other data point that we want to connect with this is the referral source. In terms of if we're missing from referral to evaluation, do we 100% of the families who make that referral themselves make it to evaluation? Then those families are ready for us. They're wanting this, right? And then versus the referral that might be coming from a social services agency, it might be coming from the medical provider, childcare provider, any number of referral sources. And maybe that referral source didn't tell the family that they made the referral.
Information disconnect.
Yeah. So that is a good point. I'll make sure that we're connecting that subset of kids with their referral source. We do collect that.
That's good.
I do have a question. The referral data then, could that be duplicative if a child was referred one quarter and then re-referred?
So that's also a great question. It could be that the children in this data from July to December, that this is their, they could have had a primary referral when they were 9 months old, and now they exited our program and now they're back because of language.
Oh, yeah.
Right.
Okay.
So there are any number of points when kids come in and out of our services. We have a number of families who leave and come back because they're now at a different
developmental stage. Yeah.
And then there would be children in this referral bucket that had a primary referral that never made it to evaluation
Okay.
in a previous set of months.
Okay.
But I think when Marie pulled this data, it was had a primary referral, because we don't want to look at kids who have a secondary, we don't want to add a secondary referral.
Gotcha.
Secondary would mean that there's already a primary one. And in this time, did they make it to IFSP? Because it's so.
Yeah.
And there could be children too that are also in the referral that their 45 days isn't up yet, and so they don't have an IFSP yet,
Yeah.
right? So
Yeah.
that's also
That's going to skew
tricky.
your data.
Right.
Yeah.
Great questions. Thank you for being so engaged in this. We're so excited to have so much access to our data, and we're
Yeah.
really trying to dig in and understand it. And we're kind of go through some of our priorities later this morning, and we'll kind of see why it's taken us a while to get there. The next slide is fiscal data. This is the same data that I shared during our quarterly business reviews. We have our service claims costs, so that's the services that we're delivering to children and their families and the cost of those services. And then our providers enter in a service encounter with a child and a family. They tell us what procedure they did, how long they were there, where that visit occurred, and we turn that into an insurance claim. And you can see our Medicaid recoupment, our private insurance recoupment, and our family cost participation. We always see private insurance recoupment dip in January. Insurance restarts.
Oh, yeah.
People have to meet their deductibles, so that's why you see that spike toward the end of the calendar year. And then the family cost participation, the reason for the sharp decline and then the sharp increase is because we identified bugs in our data system, in the system that was generating our cost participation statements. It turned out that families were receiving statements saying that they had a $0 copay when they really didn't. And so that was corrected at the end of December, which is another reason why our QBRs are so important, that we're really digging in and looking at this, that I said, why did this happen? And our vendor went and looked and sure enough found several bugs in this space. And those have been corrected, and therefore you see our cost participation collection go back up. We'll also say that the cost participation does not happen in real time, though January is really a collection for October services. So we're 4 months in arrear.
Christine, I had a question. I know it takes a while to gather all that information for cost participation. Do you have a general idea from the time a family comes into the system? Obviously, the service coordinator has a discussion, collects the information about cost participation. But there's been some discussion about families feeling like maybe they didn't know for quite a while how long, what they would owe. Do you have a general idea of what that might be at this point? How long before a family really does know what their cost participation will be?
Our service coordinators are completing all of that income verification and documentation at a family's intake. And if not at the intake meeting, at their IFSP meeting.
Okay, so
and they receive a copy of what, a generated piece of paper of what their cost participation share is, and they have to sign it.
Okay.
We are working on, well, we can move to the next slide and you'll see one of our current initiatives is family resource development, and one of the resources is information regarding family cost participation, our systems of payment, getting to know your own insurance policy. I didn't mention this at the beginning, but we are here at the state a mighty team of 9 people, And we have, while I have a very competent family engagement, policy and family engagement manager, Jamie does not have the capacity to be on the phone with insurance companies every single day. And there are weeks where that is what she's doing. And really trying to help families understand. So we're working on some resources for service coordinators to help families. I know that Family to Family has some resources about understanding your insurance policy and those types of things. So those are some of those things that we want to leverage to make sure that families have all of the information that they need. They also need to have information to make informed consent to let us bill their insurance. But we have increased our insurance recoupment by over 200% since 2021. And that means that family share of cost participation decreases for every dollar that they're in, I mean, for a penny, if their insurance company gave us a penny, we would not charge them their family cost participation. But we're also starting to see that insurance plans are changing. I saw one earlier that said that their insurance will not cover a government program. That is new. In the 9.5 years I've been here, that is a new one. I have not seen that denial reason to date. And then sometimes the insurance company does not give us the proper denial reason, which then means that their secondary insurance, which is oftentimes Medicaid, will not cover it because it actually wasn't denied from the insurance company. So we're working through those things as well, which is why we have IDOI on our ICC and we're, we have connections and resources at all of those.
Thank you.
Do you have to appeal when it comes to private insurance law? And if you do have to appeal, do you typically have pretty good luck with those appeals?
I don't know if I would say we have good luck, but we seem to be able to work to ensure that the insurance companies are getting more information that they need to help make a better determination about medical necessity or coverage for that child and family. It would be great if we had an insurance expert on our team, becoming very self-taught in that space. But definitely understand why we're working so hard to do that, and that is to benefit children and their families. The last thing that we want is that a family withdraws from our services because they just couldn't afford it. That isn't something that we ever want to happen.
Christina, I don't remember if someone is utilizing their private insurance, do your visits count against, like if they have a visit limit on their policy?
It does.
And families then can choose, right?
If families can choose to have us not give us consent to bill, and they would just be responsible for their cost participation based on their income. And we do have some families that choose to do that. What we won't do is do it retroactively.
When families decide to do the cost by themselves, is that like private, or they just have to pay out of pocket?
Both.
Okay.
Some families use their HSA accounts to help cover the cost of those services.
Those are so helpful. We use theirs.
So quickly, I'll just go over our current initiatives. We're working to close our federal findings that we received in July. We provided a response to our federal partners in October. 3 weeks ago, got a response back to our response, and we'll be working to provide some revised documents to them in the coming days, and then hopefully be able to close some of those and really focus the last 3 months of the fiscal year on implementing those new policies and procedures. As I mentioned in the video that you saw today, we're really focused on caregiver coaching. We have implemented family-guided routines-based intervention, which is a model of early intervention focused on caregiver coaching within daily routines. That's what matters to families. Yes, they want to know how to play or how to help their child put shapes in a space, but really what's important to them is their daily life, right? And getting from the house to the car, or getting up the stairs to the bath, or getting outside as a family and playing. So what is really driving that family and their routine and helping them in those spaces? We're also implementing tiered technical assistance. It's something that we felt like we were lacking here at the state, to really provide targeted support for our providers and our SPOs, so they can build better policies, train their staff more appropriately, get some guidance on how to navigate certain situations, et cetera. That's been, we kicked that off last year, and it was really successful, and have put that again in our RFP for our request for proposals for our professional development system. That contract was awarded to IU, and they will be continuing the tiered technical assistance. We also, as I mentioned earlier, are looking at our family outcome survey and really reviewing that with our interagency coordinating council. In our last ICC meeting, we dug into that data and looked at, over the course of the year, families report very high scores on that. And we get probably, I think, 55 to 60% of them back. And about 94% of families are saying we helped them, which is great. But I think we want to create some more nuanced questions to kind of dig into some of what we've been talking about today. We have and continue to work on our data system and try to make it more user-friendly, so more of our service coordinators are actually in it rather than their data entry specialists. And the thing that we're working on right now is enhancing our IFSP information in there, and that having that document within the data system, we'll be able to pull more of that data. The more that's in there, we can get to some of these nuanced questions that you're asking. We're working really hard on data-driven decision-making, pardon me. Again, hence the lunch and learns. We're going to be teaching our local providers the Look, Think, Act framework, and how you look at data, think about it, and then what are we going to do about it, and implementing some continuous quality improvement strategies. We're also, again, working on those family resources. One of our findings that we received from our Office of Special Education Programs was we needed to revise our procedural safeguards. Those, I'm pleased to say, have been approved, and so we will be moving forward with sending those out. So you all will probably receive those. If you're interested in attending a training, I know that we'll be doing one with InSource, yes, and doing them with a variety of community partners. And then last but not least is a policy and procedure review and update. Some of that is tied to our federal findings, and some of that is we've just noticed that we have gaps in our provider and policy manual that we really do need to provide more guidance and support. Some of it also is limited capacity over the years, and we have a bunch of memos and policies that we've created, but they never seem to make it into the policy manual itself. So really trying to compile all of that and have a big comprehensive manual that people feel good about implementing first steps across Indiana. So thank you for your time today.
Thank you.
Thank you.
Any other questions? Thanks, Christina. Okay. Excuse me. Turn it over to Holly. Start us off on summer 2026 waiver amendments.
I know when we met last, we talked about all the different, proposed changes in those amendments. Wasn't gonna take you all through all of that again, but did want to highlight a few things that, are the more substantial, oh, I'm sorry, thank you. The more substantial or things we've received some questions about. So, of course, one of the larger items in this set of amendments is the proposed movement to a case management before implementation. That is, again, taking the case management model we have with the family support and the community integration rehabilitation waiver and taking that across the 4 Bs operated waivers, including the health and wellness and traumatic brain injury waiver. There's also a very small number of pathways fee for service individuals that would also be included or impacted by that before implementation. So I'm going to talk a little bit more about that, what I can talk about anyway, in a moment, but just wanted to highlight that as one of the larger changes or proposed changes. One of the other changes that we have proposed is a reduction in the provider reimbursement rate for attendant care, participant assistance in care, and residential help and support when the employee lives with the waiver participant. Now that is, again, you all probably or may remember when we did an increase, a significant increase in our HCBS rates back in 2023. It went into effect in 2023. And we worked with our partners in the provider community and formulated the rate buildup. And that rate buildup included some transportation for staff going from one site to another in the delivery of attendant care pack and residential housing support. So what we have done, because live-in caregivers wouldn't do that, right? They don't go from home to home, they're in the home, is remove that portion of the rate. We have had a number of questions about that. We have addressed some of that already in a provider and case management webinar, but what I want to emphasize here is that change should not impact the pay to the employee because it is only that part of the buildup for the employee going from one location to another. And what the provider is reimbursed for that. And it should not impact the employee's ability to take the individual out into the community, to the grocery store or to an event or whatever that may be. So we will continue to
just add, because that is built into the rate.
Yes.
A specific line item for mileage reimbursement for every hour.
Community activity or community inclusion.
So that remains.
That was not attached. So just wanted to clarify that a little bit. The other change is proposed change is a move to mandating the RHS daily rate. Now this just impacts individuals on the CIH waiver, and it only impacts individuals who are in Algo 3 or higher, who live outside of the family home and who share staffing. That hasn't changed. That's the way the daily rate is structured today. The difference is if a person meets that criteria, they'll need to be in that daily rate, pending approval of these amendments. We also are proposing or have proposed some changes to service provision allowable by family members. So this would be non-LRIs. We're not changing anything we have previously discussed or that's currently in the waiver on what a legally responsible individual can provide. The LRI, a legally responsible individual, being the parent of a minor or the spouse of the waiver participant. So I want to be clear about that. What we are proposing is some modifications to what other family members can provide. On the CIH, we are proposed or have proposed that family members can provide residential habit support, respite, structured family caregiving, and transportation and workplace assistance. On the family support, it would be participant assistance in care, respite, workplace assistance, transportation. On the health and wellness, and of course in conjunction the pathways for aging waiver. It's attendant care, home and community assistance, which people often refer to as homemaker, skilled respite, structured family caregiving, and transportation. And then lastly, on the traumatic brain injury waiver, it's the residential habit support, similar to the CIH, the attendant care, home and community assistance or homemaker, skilled respite, transportation, structured family care. So we are proposing in this set of amendments that those are the services that family members can provide.
Is there something that was on the list before that is not anymore?
Well, we didn't have, so what in today's world, a family member could actually provide day rehabilitation. And what has been shared with us in a number of situations is some family members, some providers and family members were providing, for family members who work for providers, were providing, for example, day rehabilitation in the home, or sometimes in the community, but it wasn't always clear, or isn't always clear, if that is a practice that's occurring because it's addressing the individual's need for services, or if there's some other factors at play, so to speak. So we felt like it was best to, build this around. Oh, sorry.
May I layer on
Yes,
that?
you may.
And you can correct me because I'm not in the weeds all the time. I think the
Holly,
reason
there's
is it wasn't necessarily quote unquote allowed before. It was an assumption when day rehabilitation was created as a service that if it was provided typically in a facility or by a provider it was meaningfully engaged, it was never intended to be an in-home type of service. And somewhere, I think, in the last few years, that began to occur. So this was necessary, I think, more to clarify the intent. It wasn't really that you weren't really trying to take anything away. It was never intended to be done in that manner. So it was more clarity, I think, around that.
I would agree. And I think one of the things that we'll talk some more about today in some of the other proposed changes is we are really trying to, we know waiver resets on the horizon, right? But we are really trying, as we approach that, to get our system focused on outcomes, right? Not just, we're going to just deliver this service, but what's the outcome for the individual, right? Why are they receiving that service? How is that service, whatever it is, helping them get to their goals? So in really, really focusing on outcomes, one of the things that we're seeing and have seen is that some of our services, to Kelly's point, the intent, the purpose is here, but somehow over time, and that just happens, right? Things get a little muddy, and we want to get it back on track. So we'll talk some too about our documentation requirements. We've made are proposing some pretty significant changes there and that's in some service definitions about what we want to see from providers of services in terms of those progress reports, because right now they're kind of all over the board in how they're written, and that's no one's fault. That's just kind of how it is. And what we've heard from people in services and their families is they get these reports, they all look a little different, it's kind of confusing. So we've got a template that we're proposing or will be proposing and are working on that to kind of unify or add some uniformity to those progress reports. And it's really also focused on outcome of the service. You know, what happened during this progress period, this quarter, whatever that may be, and how did that help that person get towards, or how did that support that person toward their outcomes? Because again, as we think about waiver reset and preparing the system for that, preparing all of us for that, we really do need to focus more on outcomes of our services.
Holly, there's a question down here.
Oh, yes, I'm so sorry, Lexi, I'm so sorry.
It's okay. So this is kind of jumbled in my brain, but I'll make it make sense the best I can out loud.
Okay.
So I'm just kind of thinking in my head, like if someone was on CIH and was doing res hab with staff and 1 or 2 roommates, but they were to use DHI to go out in the community by themselves, and a family member wanted to take them in the community, currently provide DHI as that billable like service. Now with the amendments not being finalized, when the amendments is finalized, how could they bill that? Does that make sense?
No, it does.
Okay.
It does. So, well, I think I'm picking up what you're putting down, Lexi. I think, actually, that many of the residential hab and support in your example, right, is a pretty broad service in terms of what's allowable, and people can go out into the community with their residential hab staff. And that may be an option there, because residential hab is and will continue to be a service that a family member could provide. Particularly if you're talking about day hab individual, you know, that would be an option in that situation. Does that make sense?
It does, totally.
Okay.
Thank you so much for answering.
Oh, no
the
problem.
question.
It's a good question.
Thank you.
And thank you, Jim. I did not hear Lexi. Any other questions? Okay. We'll move on through. We are proposing a benefits counseling service limit of 6 hours a year. That particular service, as you guys know, is very new. And it is meant to be intensive, not something someone would stay in for an extended period of time. So we are proposing that 6 hour limit per year for that.
Are we seeing that used quite a bit since it became a service?
It's been a little slow on the uptake of people adding up, but that's not unusual, really and truly, when we start a new service. Like when I think, Lexi, again about like career exploration and planning, kind of a slow start with that. But I think the utilization of that will increase as people get accustomed to it being an option, if that makes sense.
So that's good.
Yeah.
It's a good service. Because really all you need is a couple hours of it, not for them to like get your information from your benefits and meet with you and send you the paperwork and stuff. It's a lot of it they can send to you and explain, and then you have it for future reference. So you really don't need a huge.
Yeah, I think you're right. I think it depends on the person and their situation, and if their family needs some additional conversations around employment and what that might look like, and that sort of thing. So, but we are excited about that particular service.
Me too.
As a way to encourage people to explore employment.
It's really helpful. I got it through VR a while back.
Oh, yes.
So.
Yeah. We are also proposing adding the reserve capacity for money follows the person on the CIH waiver. That is necessary because of the next bullet, which is removing the reserve capacity category on the CIH waiver of individuals choosing to leave an ICFI ID. That was the category that was most often used for money follows the person, was someone choosing to leave a group home and go to the CIH waiver. Sometimes they use the money follows the person. So because we're proposing to remove the ICF IID reserve capacity, we need to add the money follows the person. As a reminder, the money follows the person is 365 days of eligibility, and we have to ensure there's a waiver at the end of that eligibility period, if the person continues to meet eligibility and if it's needed. Yeah.
Just wanted to clarify, so if somebody does choose to leave an ICFID, they can still access money follows the person, but they're not, so how would they get out of the institution then?
We could look at other potential waivers, like the family support waiver, and there is a waiting list for that, but those other waivers we can look at. And natural supports and other resources.
With the daily rate mandate, how would an STBR, I guess, be utilized then, or there wouldn't be any STBRs? Sure.
There potentially could be. We're working on an IT solution for that. There could potentially still be availability of that for sure when there's a temporary change in the person's needs. We just have to figure out the IT piece.
Gotcha.
Because currently the IT system is somewhat limiting in how we can go about doing that. So for those that don't work in our IT system, I'll explain a little bit about what Ward was talking about. Our IT system today requires that if someone's on a daily rate and they need an additional boost of services, because maybe they lived at home with their caregiver and their caregiver was in the hospital, for example, and they need a little boost of the RHS, residential housing support. Today, that person's plan has to be converted to an hourly rate, and then they can request additional services. And then, they can return back to the daily rate after that. Very complicated, a situation where our system just doesn't work the way we would really need it to. So we're working on an IT solution to address that.
Thank you.
We'll remove some administrative burden for case managers.
Say it ain't so.
Yes. So, and we want to streamline wherever we can. Thank you. Kelly just did a very quick reminder to me. Thank you very much. The ESN, Melissa, to your point, and Sierra, they can still have access to NFP.
Yeah, okay, thank you.
Yeah. And Kelly, she's very good at that, so thank you for that. Any questions on any of the other items for those summer amendments before I jump to the B4 and case management?
So,
Yeah.
on the CIH waiver, are they gonna change, because I'm on the highest one, are they gonna change anything if the person is on the highest one? Like, I don't know how to word it.
That's okay. And I think maybe are you asking maybe about waiver reset and that will change? We're gonna get to that. Okay.
Sorry.
No, there's no reason to be sorry. No reason at all, but we'll get there.
Okay.
Okay?
All right.
No reason to be sorry.
And for the case management, like,
Yes.
I've had about 7 case managers come and go. But recently, this year, I've had about 4 case managers. I had Chad, who was amazing, and I had Kaylin, and then I had Allison, and now I have Hillary. I'm just like, why are case managers putting on the spotlight? Is it too much for them, or it's frustrating because I've had so many case managers over the years.
Yeah, maybe we can talk after about this. If not today, we'll connect online and talk through that. Okay? Because I hear you, and I know that turnover is not easy on anyone.
No, and I don't.
People we support, but also providers, you know.
Yeah, I don't do well with like change right away, but like it would just came out of the blue last week and I'm like, great.
So we'll connect if that's all right.
Yeah.
Thank you. About case management, thank you for the segue into that. A couple of things.
Holly, you want to move?
Oh, yeah,
Good.
I'm sorry.
Are you good?
No,
Move to the next.
Oh, that's perfect. Thank you. With the proposed new B4, we are allowing for regional coverage with preferred statewide coverage. So as the case management is provided today on FS and CIH, those selected vendors through that process back in 2021 had to be statewide. They had to provide statewide coverage. In this iteration of selective contracting for case management, again, we still prefer statewide coverage, but we are allowing for regional coverage for those entities that are submitting proposals or have submitted proposals. It also is including some value-based payment elements. I spoke a little while ago about outcomes of services. That includes case management, right? We believe, I think we know, we don't just believe, we know case management is the cornerstone of HCBS. If we don't get that right, everything else isn't going to be as good as it can be, right? And we know that we've got continued work to do there, and we think that, or believe that value-based payment is one way to help incentivize and support those case management entities or organizations to provide quality services. So this B4 includes some elements of value-based payment. At the end of the process, we will have up to 9 case management entities. I don't know how many, just up to 9.
What is it right now?
I'm sorry?
How many is it today? 5 or
6.
6, okay. Thanks.
It's no less than 1.
Oh, I don't remember for sure, no less than 3.
No less than 3,
I think.
and up to 9.
But up to 9, so there's a pretty wide range there.
But there's a lot more than 6 for health and wellness currently.
Yeah, currently there's, if we look at the totality of case management across the 4 waivers, there's about 37
Right.
entities.
So would then it be encouraged, or is there encouragement or a plan for those that get accepted if they have regional coverage to eventually move to statewide coverage if there are going to be potentially only 9 taking on the work of 37?
We did not put that in, well, let me back that up.
Can I actually
That
say
is a
something
potential,
though? Just to put it into perspective, just to put it into perspective, the CIH and the FSW, what we serve approximately 35,000 people. And so those are supported by 6 entities. The health and wellness and TBI together, we have 14,000. So that are now supported by 30 some odd. So really part of this is to improve our ability to monitor quality, consistency, and the transition will be a part of.
yes, yeah, the transition will look a lot like it did in 21 to 22 when we did, when we moved to the B4 and the FS and CIH. To Kelly's point, this selective contracting process impacts fewer new people to that kind of model than what it did before. Currently, those 37, 38 entities, some of those entities serve a whole lot of people and some serve 2.
Yeah.
And as you can imagine, going back to our discussion about case management being that cornerstone of HCBS and how we really have to get that piece right. Being able to administer or oversee case management with that many vendors or that many providers very difficult. And we want to support case managers to provide quality services. And in order to do that, we need fewer providers. We won't have fewer case managers because the need for case managers is still there, right? We just need to have fewer providers of that. So we expect, and this could slide a week or two, but we would expect to issue awards in April. And then the transition period would be April through July, where we would be doing a lot of communication with individuals and families, a lot of communication with case management entities, a lot of very intense work with case management organizations that are chosen through that selective contracting process, a lot of monitoring individuals as they work through that transition to choosing a case management entity. So again, the anticipated effective date is August 1st, pending approval by CMS of the B4 and the amendments.
You
So
probably
we're
can't.
excited. Yes, Lex.
You probably can't predict this, but you expect the 6 case management agencies for CIH and FSW to stay within those 9, or you probably can't predict?
Yeah, I have no idea, Lexi. I can't predict that at all. I understand why you're asking. I do. But I wouldn't be able to predict that.
And which of the 6?
Exactly.
Just cut to the chase.
Thank you.
No problem. No problem.
And then similar to the elimination of a managed care entity, if someone were to not choose a new case management, say their case management company was not chosen and they didn't choose a new one by the time, they'd just be automatically reassigned then at that point?
Yes, so when we did this in 21, we actually had, and we'll be monitoring it very closely. We'll have everybody on the list, right? And we'll be checking to see when they've chosen and if they've chosen. We'll utilize case management entities to support that work as well. But yes, we will have a date by which people need to choose. And if they don't, we'll auto assign, but they can still change, right? But everyone's got to have a case manager. And when we did this the last time, it was interesting because we did have some families. Yeah, it was very, very few that we had. But the families that we did have and the individual we did have, they just said, I don't want to choose. I just don't want to choose. I'm like, okay, I don't, yeah. I mean, when my doctor leaves the practice, I'm like, I don't care. Just, you know, I mean, just assign me to someone. Not minimizing it at all, just saying sometimes people are involved and they're like, just make the decision, knowing they can change it whenever they want. So yes, we will have that piece to that, that transition process if we need it. But again, last time it was very few. And they were individuals that knew, because we had personal communications with them, our leads office did. And they just said, I don't want to choose. So what I don't know is how many who didn't want to choose then changed later. Yeah. I don't know that. That would be an interesting thing to follow through. But yeah. So we're busy gearing up for that process. Next slide, please. Just the timeline, public comment closes today on the amendments. And I didn't specify, but again, that's the BEADS waivers and the pathways for aging waiver, BUNC, that are out for public comment. And again, that closes today. Tribal comment will close at March 29th. And then we do plan to submit to CMS by the end of April with the anticipated effective date of August 1. And we have gotten some public comment and are working through that now. So, of course, we always get some the last day. So, you know, we'll be getting some more, but we have gotten, I would say, a healthy amount of public comment. So, which is good. And we did our webinars trying to make sure people were aware of how to get public comment and where to find the waivers and all that as well. So, any questions on the amendments? All right.
Okay, Holly, before you move on, I'm going to take a quick break. Does that work? Just for our, we were kind of ahead, but now we're almost to the time.
We were ahead after.
Yeah. Well, no, we aren't. We're still a little ahead, but we're going to take a 15-minute break. So just make sure to come back if by 11 o'clock, and then we will start right back up with waiver capacity. Okay, we're going to go ahead and get started. Thank you for indulging my needing a break. As everyone knows, I usually do. We are going to turn it back over to Holly to give us a waiver capacity update.
Thank you, Jess. Okay, so waiver capacity, just wanted to provide some data for all of us to, in the interest of transparency. With the family support waiver, the CIH, health and wellness, and traumatic brain injury waiver, the second column there is our capacity in those waivers. So with the family support, we have a capacity of 26,199. Well, as of 2/28, February 28th, we had assigned slots of 25,451. Open invitations, including reserved capacity, we had 548. This is kind of what we refer to as the pipeline. So the people that have been invited or people that have met reserved capacity and they're in the process. They're not yet active. And as of February 28th, we had a remaining capacity on the family support waiver of 200. So we are looking at filling those. As a reminder, the waiver year for the family support in the CIH is July 16th through July 15th is the waiver year. So on the community integration rehabilitation waiver, we have a capacity of 9,438 and we are at capacity. So we don't have any open invitations. We're not moving anyone into CIH right now because we have no slots. On the health and wellness, the capacity is 16,127. We have 14,329 slots assigned. Open invitations, 1,209. What that means, again, those are people in the pipeline. Some of those will go all the way through to active, some will not. And we do have across all the waivers that resend process, where if individuals don't move through the process and go active, their slot will be resended so that we can support and move on to the next people on the list. We have remaining capacity at the end of February on the health and wellness of 589. We are inviting an additional 300 people this month to the health and wellness this week, to the health and wellness waiver. So that remaining capacity will.
What was that number? I'm sorry, 200, 300.
So then if 300 more invitations are going out, and then that would leave the remaining capacity around the same number as the family supports waiver. Does that mean that there's a potential pause on invitations there as well?
On the health and wellness? Mm-hmm. Yes, but not, I don't think that's likely, and let me explain why. Because that resend process, like 100% of people don't go through, right? And that resend process has been in place on the health and wellness and pathways for aging waiver for quite some time. We just recently began that process with the FS and CIH and TBI, but it's been a process on the health and wellness waiver. We see a little bit lower throughput on health and wellness of people getting all the way through that process. So, yes.
So I have a question about the CIH that I've seen like on the family sites and things and whatnot. My understanding is that the CIH is considered an emergency waiver. So you have to be in an emergency to get on the waiver. And so when you say that there are certain, and I understand budgets and money, and, you know, there's no infinity. It was, I don't know, it was stated some way that I'm not remembering right now, but so if someone were to have an emergency situation where like if my daughter, if my husband and I were killed tomorrow and she had no caregivers, there's just nothing.
So-
Right? I mean, what you're saying is that there are a certain amount of slots, and right now she's on the family services waiver. And if something tragic happened and she needed supports, which is what my understanding of what the CIH waiver is for, what would happen?
So let me back up a little bit, because I think that's a great question. The CIH waiver is often referred to as the emergency waiver. It's a needs-based waiver.
Sure.
And it has different categories of individuals with certain needs that can access that waiver. They're not all emergencies, right? Some of them, as we talked earlier, have been individuals choosing to move through homes.
Sure.
Right? Those are emergency. There are some emergency categories, and the data that we sent out, does kind of indicate, or doesn't kind of, it indicates what those categories are. So the emergency categories are the health and safety, as determined by the division director, the abuse, neglect, and exploitation, which we haven't had any of those this year, death of caregiver, and then caregiver rating. So
right.
Just wanted to clarify on that point. If parents of an adult's living with, an adult with a disability is living with their parents, and their parents, as you gave an example, which we hate to even speak about,
sure,
but need to, right? There is still the option of supervised group living for those adults. That would still be an option. Continuing on the family support waiver and looking at, is there state plan services? What are those community supports that are available? Does the person need some support from the community mental health center? Even if it's just for the grieving process. Our teams, case managers.
Yeah, I'm thinking about people like my daughter who require 24/7 care,
right.
that
sure.
If there's supports, I'm just like zero. I don't know if a group home would have a spot for her. Like,
we've got over 12% vacancy rate, 12% vacancy, 12.5% actually % vacancy rate in supervised group living. So I do think it's an option.
Well, and I think the new Inter-I suite of tools will help with this, but I've heard of instances where there's people on the CIH waiver who, by choice, only use case management and don't want to use any of the supports, but yet they're taking one of those slots. And I think the Inter-I should help with that, but that's definitely a concern of mine, because I've heard of that being the case. And I've heard it was their choice. They didn't want the services, but yet somebody assisted them in getting the CIH because I guess they felt they needed it and they're not using it, and that's taking a slot.
that's a waiver reset.
That is part of the reason that we are doing waiver reset, because the current structure actually doesn't afford the flexibility.
Yeah, I guess I'm just going to put it out there that this seems worrisome, as someone who will eventually turn 80, that's an inevitability. And I'm sure that there are a lot of people who will turn 80 this year who are full-time caregiving for their children.
That waiver year also ends July 15th. There will be turnover, vacant spots, so there will be slots available. And then, as you well know, a year later, we're targeting for the launch for reset. So it's not that there, from now till whenever, there won't ever be another slot. So,
and there is a very modest increase in slots for the next waiver year. It's very, very modest. But to Kelly's point, there are people through the waiver year that leave the waiver.
Sure, I mean, there are people that die, and it's interesting that I don't know if that's a consideration, if that's like a federal law that the waiver year, if someone were to go away, leave the waiver, and you have an empty slot, is that a federal law that we can't change? We can't backfill that during the year if something were to happen that's a hard situation. we have someone who has stepped away or passed away or whatever, and that slot is sitting empty until July 16th. And then it magically opens up, you know, while people suffer from, you know, March until then or whatever. So I don't know if that, is that something that could be changed in the waiver reset, or is that like a statute that's written in stone?
When an individual has occupied a waiver slot during the waiver year, and let's say, I'll just use an example. Let's say they move to a neighboring state. Sure. And they come back in that waiver year.
So they would still be eligible to,
yeah. If it's in that waiver year, they're going to say, that's theirs because it's no duplicate account, so.
yeah. But if
But we are
pass away-
always exploring and looking at ways that we can maximize the slots available to support people. I think we're all aligned on that. As you pointed out, the slots, and we've talked about this, there was a pie, right?
Right.
But we are always looking at how can we, you know, most effectively utilize the resources we have, of course.
But I think to answer your question, no, it's not in statute anywhere. It is a practice, and it's mostly around fiscal driven practices, but there's not a statute that says this is the way it has to be done.
Is there still priority status for folks coming out of school or military families for the ones that do have available slots?
Oh, you're talking about the family support waivers?
Yes.
Yeah, those, the only proposed changes we're making to reserve capacity were what we talked about earlier.
Okay.
Yeah.
So
So the
there's-
18 to
those are still-
24 leaving school is still a reserve capacity on the FS, and the child of an active or veteran of the U.S. Armed Forces or National Guard. But now if there's no slot, like once the slots are gone,
Yeah,
the slots are gone.
okay.
For that waiver year.
Yes.
Yeah.
But they still have priority.
Those are still reserve capacity priority categories.
Thank you.
So if I'm utilizing a waiver, it's the family supports waiver today,
Mhm.
and I move to Ohio, and I come back July 10th and say, I'm back, I get my waiver spot, but if I came back July 17th, it means a reapplication because the new waiver year has started?
Technically, yes. Now, we look at every situation, but technically, yes. And I want to give a different example here. If someone's on, let's say they're on the FS and they're in the hospital for an extended stay, right? And that crosses that waiver year, right? We would look at that.
Sure.
Right? Because that person didn't voluntarily leave services, right? They were in a hospital. So we would look at that. And see what we need to do there. Again, our goal isn't to, pull people's waivers from them or anything like that. It really is to how can we support these people with resources we have.
Absolutely. Yeah, just was curious about.
Yeah, no, it's a good
Then
question.
just a really direct point.
Okay,
If somebody,
Brad, I don't know.
I know that's fairly aggressive. I know. So some of those examples are, many of those examples are of somebody moving, coming back. If somebody does pass away, they're not coming back. And presumably our average age in these waivers is aging similar to our just general population. No? Okay. But we do have older,
No, it is not.
but we do have older people on there. We do have people that pass away during the course. I mean, so are we just waiting to fill that then the next year? I think that's maybe at least the point that you're trying to get to.
I didn't even think about people moving away. That's great that you.
Because that is final. And then say if somebody passes away in August or September, I think and I don't mean to put words in your mouth, but that 0 openings isn't entirely reflective of the reality of, well, 2 people passed away so anyway, I think that was really maybe a little bit of a question. Sorry.
It seems like a great way to save money for the state. Is how it is perceived, I think, a lot of times by us just normies out here in the world. You know, it's a great way for the state to save money to only fill when on starting January 15th.
Yeah, well,
Or July 15th.
and I'll say it in a similar, or in maybe a different way, but I think that's one, I don't disagree how that looks, but I think on the other side is, there's also people with major needs in September that, that slot that has been budgeted isn't being used. Somebody clearly has a need if we're at a reserve capacity rate of 0. There's clearly need that's waiting to get into here. I mean, you look at the wait list and that. Why are we just letting that sit unused, those dollars? That, I think, but anyway, I just throw that out there.
I do want to clarify some, because, CMS focuses on, the term slot is used, and what they're really talking about is a duplicate account, right? And they really do hold states accountable to ensure that they are not willy-nilly filling slots, right? Or that we're not, if Kelly is in a waiver and she goes into a nursing home, or sorry, or something can happen. Should have chosen a different setting. But anyway, let's just say she did. CMS really does watch that. Like if we went and filled that slot, that would be problematic. That would be really problematic. And we don't want to do that anyway from CMS's standpoint.
Because she could come out, is what you.
Right. And that would not be the right thing to do for her, but it would also be a problem for CMS with the state. So states, and believe it or not, slot tracking that unduplicated account, when you're talking about 50,000 people, and each one of them has their own situation, right? That is not an easy task, and that's not an easy task in Indiana, that's every state. It really is.
As well as even when someone is deceased, verifying the passing.
So most states often don't even dip into those slots for individuals who have deceased during that. And again, we are always looking at ways, how can we maximize?
Not that we're not looking at all
Yeah.
things. I do not dismissing that. I don't want you to think that. I think the other thing that I do have to share is all states, but let's just speak specifically to ours, when appropriations are made, budgets are set, that is based on looking at historical data, and they use what is referred to as a PMPM or PMPY, per member per year. So we had this number of people active, right, active claims, this was the cost, this is the average cost per person. So that budget is calculated on that, not we have authorized budgets out there for X. So then that's also, by the way, why we're moving to waiver reset, is that the framework that we're proposing, and I'm gonna let you get into that, would allow us to better predict if we, on waiting list, what would be the cost should we increase capacity. I use that word rather than slots because I hate that word.
I know for case management, just because somebody has passed, we still have quite a bit of work to do between the mortality review and the utilization. And I can only imagine that administrative burden carries over to, beads as well. It's not an instantaneous, no.
Yeah,
No, it is so not. Right.
Absolutely.
Right. So I think it allows for that wiggle room too. It's helpful.
Thank you for that. That's
really
helpful.
great conversation.
And this is the first year I think that number's been 0 on this, at least that I've known of. But and that's why these conversations are different, or it feels different, like for people who think of it as an emergency waiver.
Yeah.
No, I think this is really good conversation and discussion. And actually, I like the discussion as opposed to me just talking.
You got it.
Can we? Oh, well, I didn't finish, did I? Okay, we got stuck at the CIH maybe. Health and wellness, I think we did talk about that. The traumatic brain injury waiver, I did just want to mention there. 200 is the capacity. You can can see we've got remaining capacity of 2. We've invited people, I think, since the end of February to those remaining slots. Again, that's a very small waiver, but still important. So, but I think if we can go to the next slide, Jess, as we're, oh, I'm sorry. Yeah, oh, I'm sorry.
Hi, quick question. And I think you said this, the waiver year that does or does not apply to health and wellness?
The waiver year for health and wellness is July 1st.
Okay,
Through June 30th.
gotcha.
Now, let me double check that.
And then,
It's not the 15th. I think it's first. Now, TBI is January 1.
Not fun.
Seriously, yeah.
They're all, that's the other thing. So we get them all on the same.
Waiver reset, waiver reset.
There's something amendments coming.
and then this may be too soon, but the new waiver that just passed in legislation, is that, I don't want to like add more into the mix, the assisted living. That passed? That passed? It did. Or is that
77.
too soon?
Yeah.
Okay. I don't even, it's just a dream. It's not bringing it up. Okay, sorry. I withdraw.
1277.
Okay.
It's March. Right? Yeah, I know, I'm sorry.
Yeah.
It's gonna snow.
But the way it is written, I mean, the only thing I guess Ken you probably know this better than I do, is that slots, just to speak plainly, instead of capacity, slots would move from the pathways waiver to any new waiver that were developed around.
If it's approved by CMS.
If it's approved.
And health and wellness, July 1. I just verified that. I wanted to double check on that.
Was that going to be your question, Melissa?
Yeah.
Okay. I thought I was being a little anticipatory there.
Any other questions?
Can I offer a point of clarification, just with regard to the rollover of slots and the year? Absolutely, there's nothing in rule or statute that says you can't backfill. But what is in guidance is the technical guide from the Center for Medicare and Medicaid Services. And if read plainly at this point, it does indicate that it is unduplicated in the year. There is now some more flexibility and there is some openness to rethinking that. But for many, many years, for always, clear guidance that everyone has agreed on is that per the Center for Medicare and Medicaid Services, it's one person within 1 year, even if that person leaves for any reason. So that is also another reason why that is common practice today.
Thank you. All right, can we move to the next slide? Because I think all of this discussion is the perfect lead into some additional conversations around the goals of waiver reset and what that might look like. I know you all have seen this before, but I think it's worth talking through again because it's a pretty big thing. So we want to make sure we leave time and space to talk through it. And sometimes it's helpful to hear things more than once. So again, the goals of the waiver reset are to simplify the system. We know, we hear it every day, that the system is difficult to navigate. And we also have talked before about, the number of assessments people have to go through today. There's the level of care assessment, and then there's the level of service assessment for certain services, and then there's, different assessments. So it's a lot. So we want to simplify all that. And then, of course, updating services that are offered. Improve support coordination. We can call that case management, support coordination, care coordination, whatever maybe you want to choose. But again, we know that that's key, that whatever entity is providing support coordination, case management, care coordination, care management, that entity needs to be knowledgeable about all resources. And they need to support people in building informal supports, connections in their community. Again, looking at those outcomes the person has, their goals, and how are we supporting them to get towards those outcomes. Kind of keeping that train moving with the individual driving it. Enhancing quality outcomes. We know we're going to have changes coming with waiver reset, and we want to make sure that we're positioned to support providers in learning about any potentially new services or new methods of delivery of services, and also support them in working towards quality outcomes from their services. And then we mentioned we're introducing some value-based payments, or use an acronym, in case management, but really how can we look at taking that across different services as well, right? Again, that focus on outcomes for the person. And then last but certainly not least, ensuring that what we develop and implement as part of waiver reset is sustainable. And going back to case management and support coordination, to be sustainable, we really have to take a holistic look. We have to support people in building those additional informal supports or connections in their community in order to have as one component anyway of a sustainable system. We're going to talk some about the Use One assessment to fully understand people's support needs. So we have launched the Inter-I for ICF IID level of care. Yes, Jim.
So on that point, I haven't looked at like all the components of the Inter-I, but I believe that it doesn't, when you look at the array of services and waivers, the Inter-I is not just plugged into, okay, this, if you get this score, you get this amount of PAC or this amount of rec therapy or music therapy, or even behavior. There's no like separate scale for behavior is my understanding. And I don't quite understand how one assessment is going to assess everybody's full array of needs. Obviously like right now what we have, and I'm not suggesting that everybody, loves the algo or anything like that. But right now the algo spits out basically a budget, right? And then everybody kind of says, okay, well that affords you this much behavior, or this much day program, that kind of thing. It used to be bucketed for the family supports waiver, for example. How is the new assessment, which has already been approved for the level of care assessment, right?
Yes.
But now we're taking data to look at, okay, in this year, we're going to take data, and then next year, we're going to try to extrapolate from that what people's budgets and what their needs are. And how can you extrapolate what their needs are if the assessment doesn't actually measure those needs?
So let me get through this slide and then we'll talk some about that. We'll talk about the support budgets and the budget, support budgets too. Yes.
I did my Inter-I on Monday.
I'm sorry?
I did my Inter-I on Monday.
Oh, did you?
Yeah.
Okay, all right. I don't want to know how it went, but we'll talk later.
Yeah, we can chat after.
Okay, thank you, Lexi and Jim. I'll get to your comments here on the next slide. We can actually, let's go ahead and go to the next. Oh, you're there. Thank you. So the Inter-I assessments today, again, as I just mentioned, we're using it for eligibility today. And as Jim pointed out, we're going to be collecting that data, right, from those assessments and people in services, and reviewing that. And we've got a vendor engaged to review all that and analyze that data. From that data, we have the individual's needs. Now, Jim, you mentioned you hadn't necessarily seen the Inter-I, and I will tell you, it doesn't like have a specific question that maybe addresses music therapy, right? But it is very comprehensive of the person's needs. And it even, and I think I've talked about it here before, it is comprehensive in that it isn't a tool that, again, we just plan to use for eligibility, because it is very helpful when we start talking to people about what resources do you need. Every one of the tools, even the tools from the interest suite that we use for the nursing facility level of care, have a couple questions around the environment, right? Our waiver services don't address the physical environment, but it's something teams need to know, you know, so that they can connect people if they need to be connected to Repair Affair. I hope that still exists. Repair Affair, because they need, you know, some repairs in their bathroom because the tub's leaked for the last 10 years, right? And they're structural damage. So they are very, very comprehensive. But the system will be a little similar to the ALGO process today, in that we'll have a support need identified from the inter-I, but we'll also look at the individual's living arrangement and their age, and potentially some other factors that will inform that support level tier.
So basically what's been commonly referred to as the black box of the ALGO score is there's still going to be components that go into that, but what's coming out of the inter-I will be basically an intensity assessment, like a single score intensity assessment, because you can't just like invent from an assessment that wasn't really designed to assess specific needs. You can't really just invent like, okay, we're going to say these 6 questions speak to behavior, because that's just not how statistics and assessment works. So I mean, is it just a big assessment, or I'm sorry, an intensity score that then gets?
No, the support level will be the information and data from the inter-I, and I think I'm going to answer your question. Okay. So along with like the age and the living arrangement, those other key components to help identify people's needs, right? And then from that, we will have what's called a model service mix. So we'll look at and say, okay, this person is in this tier of support level need. This would be the typical model service mix for someone with that level of need.
Okay.
That information will be shared, of course, with the individual and their team. They won't have to go with that model service mix. Obviously, they can choose what services they access on the waiver to address their needs. But that will be kind of a guide, and that model service mix will inform the support budget.
Okay, so there will be that flexibility. Thank you for that answer, because this is, I got to say, this is what kind of keeps me up at night as far as waiver reset, is refiguring 26,000 budgets based on an assessment that doesn't necessarily speak to what those specific components are.
Well, I was just going to say, when we speak to budget tiers, it's a range. So there isn't you're not going to plug something in and come out with there's X amount of dollars for behavioral support, there's X amount. It's this person falls in tier 2. And let's just say tier 2, I'm going to use small numbers so it'll be so ridiculous, won't be quoted anywhere else. It's $0 to $25, right? And so some people might fall for $1 and some of the 25 after that person-centered planning is done, using the model service mix as just kind of a starting point, catalyst for conversation.
Okay.
Does that?
That actually answers my question better than I thought, just because I like the fact that there's some flexibility, because that it's scary to see a kind of an objective assessment then be the final word on individuals' budgets, and it doesn't sound like that's what you're
No, the support level tiers will exist, and then there'll be support budget tiers that are related to the support level tiers. But none of that replaces or should ever replace those discussions with the individual about these are your assessed needs. This is the array of services available on the waiver, right, that can address some of those needs. And those discussions, that person-centeredness isn't going away.
Perfect.
The model service mix is just a guide, right, that can be used to inform those discussions, but it's up to the individual based on their needs.
Thank you.
Any other questions? I feel like maybe there might be
I know I'll probably say it like a broken record, but we would really like to have a printout of what the answers were so that we could provide that to folks too, like just to.
I'm sorry.
What we've answered or what we've, what has transpired from that interride so that families can have like a record of what they've,
Oh, you mean the
Yes.
printout?
Yeah.
Yes. So to fill in that gap that Lauren just mentioned, today, because we just rolled this out, right? We're still working with our team to be able to print out that full assessment. Now we can screenshot and give it to the individuals, right? So they have that and they're the ones participating in that assessment. But the actual print of the report of the answers is not yet available. But you can screenshot those responses. It's just.
I just know like with appeals, and it's a lot of good information, even without appeals, but it's a lot of good information for the entire team and being able to share that.
Absolutely.
Yeah.
Absolutely. And again, we can.
Yeah.
You can.
It's
you can
just tedious at this
screenshot it.
point.
It's
Yes.
not friendly.
Yeah.
It's a lot more work, but I want to be clear, we do have the ability to share that with individuals and families. We just had a discussion this morning about when are we going to be able to print out the and not do it via screenshots.
I'm not going to let it fall off your radar.
We're working on it.
So if a family requested that and we're told, no, we can't provide that.
We can provide that.
But if they're told no, because misinformation, confusion, whatever the case, what's their path of recourse?
If their case manager says they can't give them that, then I need to know that. You can let myself and Heather know, or Lisa Davis, whichever. Yeah, definitely let us know that. And it's a little work heavy on the case managers right now. But it can be done. It should be done if people want a copy of it. Any other questions?
On the whole slide or just what you've reviewed?
I'm sorry, what?
On the whole slide or just what you've reviewed so far?
Oh, well,
Is there-
I can go back to the slide.
No, because I have one more question about this slide. I wasn't sure.
Okay, no,
Okay, all right. I apologize.
okay.
Thought you were moving on.
Okay, so we have this importance tier. And people will have, again, tiers, right? So that people that have similar needs will be in the same tier. Then based on those tiers, there will be support budget tiers. Couple things I know we've talked about, but I want to be transparent about. Again, those support budget tiers and what that funding looks like will be dependent on funds available, right? Which can make it more equitable as well. But each tier will have a budget range with a ceiling or a cap to that budget range. Individuals can always use less if they don't need it, right? But there is a range. So individuals with less need, their budget range will be lower. And individuals with higher, more complex needs, as an example, would have their budget tier would be higher. The other things that go into the sustainability include, of course, the number and type of waivers. That's still under discussion. Simplification of the service rate, we already talked about that. We've heard from a lot of families. We've heard from providers too. There's just so many services. and it's a lot for families to take in, right? So we really are focusing a lot on how can we simplify. Not saying this service isn't offered anymore, but how can we simplify and have less than 27 services on one waiver, right?
So that's kind of where my question lies. So with across the waivers, let's say like health and wellness, for example, does not currently have behavior support. Is the idea that there's going to be some evening out across waivers of like what's available? I'm not feeling like, you all are getting rid of a bunch of services necessarily. But it might be something where there are probably people out of that 14,000, I think that's the number that you said around health and wellness, who could benefit from certain supports that are not currently available, but are available on other waivers. Is that possibly part of waiver reset too?
Absolutely, because when we go back to, years ago, when we started talking about waiver redesign, and now we're at waiver reset, one of the things that we've heard is, what services I get depends on my diagnosis, right? And we really want that cross disability waiver array, where individuals can access those services that they need based on their assessed need, regardless of their diagnosis. So I don't know for sure, but it would make sense. And what we've heard is, today, if someone's on the health and wellness and they have an IDD diagnosis and they want behavior support, they can't get it.
Right.
Right.
Exactly.
So that's one of the things that we've heard from those we support, that they would like to see that.
Okay, thank you.
Any other questions? Again, the established budget tiers and caps within each waiver, and then the slots assigned according to the population needed and the Medicaid physical capacity. So those are all pieces and levers for our cost containment, our sustainable system, and even our quality, ensuring that we're building in quality as we look at waiver reset and plan for that.
Next slide. Next slide, please.
Sorry, please.
Oh, it's okay, I'm sorry.
Being slow. I don't know why it's like taking a minute. No, you're fine.
So just a reminder, we did the waiver reset engagement. That was September through December. We talked about that before. We're now in phase 2 of the waiver reset engagement, and we have our support budget. Our support budget community advisory board, yes, met for the first time virtually at the end of February, and then they are meeting in person today. That meeting in February was really more of an intro, but we'll be digging into the meat of things this afternoon with that committee. So looking forward to getting that up and running. All right, any questions? At least of my information.
That's actually it, Ellen.
I know we got the data out today. So if the BEADS data, so if you have questions on that and we don't get to them today, let me know. Okay.
Yeah, go ahead.
I do want to, something that you will see is we have seen a little decline in our applications overall for BEADS services, which we haven't seen in quite a while.
Holly, you said decline in what? I'm sorry. I could.
Our BEADS
Oh,
applications.
yeah.
So, it's not a huge decrease, but it's a decrease. And again, we haven't seen that in a while. I mentioned earlier the vacancy rate in our supervised group living is about 12.5%, which is a little higher than what it has been in recent years. Not a huge difference, but it's been running about 10%, so we're up to 12.5 now. So, just wanted to mention that. We're still seeing a large number of youth on our waiting list for the family support budgets. 80%, right? 17.
Is there any data around the ages of people waiting? Like who's waiting for services?
There is, yeah, and that's in that data. Now it's blocked pretty broadly, like 0 to 13, and then 14 to 17, and then adult. But yes, we do have that data and could, drill into that more. It's interesting in the data because the family support waiver, kind of has that large youth population. And when you look at the health and wellness waiting list, it's just the opposite. There's 57 people under the age of 18 on the wait list. Wow. For that health and wellness waiver. I mean, the difference is very stark. So, and while we're talking about the wait list, Kelly commented this earlier, and almost let it go by. One of the things that we'll be doing in the future is looking at how we can use that inter-eye assessment for people on the wait list, right? Like as they come in the door today, they're being assessed using the inter-eye tool or tools, whatever age appropriate tool is appropriate for that person. The people on our waiting list will want to assess them at some point as well, so that we can predict those costs of, bringing people off of that wait list.
Which tier they would enter.
Yes, which is a very positive component to the support budget or the support level tiers, because it does allow us to be able to answer questions about the people on the wait list. How much would that take if you wanted to move X number of people off the wait list? We'll have that available.
Is there a potential then that slots would be divided by those tiers? So say there's, as it states, the family support waiver, with the different tiers that they're entering into, would the slots be divided into like 200 at tier 1, 200 at tier 2, 200 at tier 3? No.
CMS would likely, yeah. The reserve capacity.
Within a waiver.
Yes, that would be a waiver within a waiver.
Not allowed.
CMS would be like, no. But there can still be reserve capacity, right? Or certain populations that need eligibility.
That gets really complicated.
It does. Yeah, it is. It does. It is complicated, but it's worth it.
Yeah.
That's what we talk about all the time. It's not a lot that's easy, but it's all worth it. So. Yeah. Any other questions?
So will the, I guess, quote unquote, emergency type, I guess, I can't think of the word, but like, will a tier be emergency based like the CIHs, or are we kind of getting rid of the emergency based thing?
Lexi, I don't know that we would have an emergency. I don't know. We're in waiver reset. We're gathering information and feedback. So I don't know that we would have an emergency category. Yeah, I don't think so, but we need to work through that, right? I see that as kind of a separate issue than
Reserve capacity.
Yeah,
reserve
capacity.
capacity plan for.
Yeah.
I think to what you were speaking, each year there might be emergent situations where it would not be best practice if we're gonna have a waiting list that someone has to wait.
Right.
Even so if that would probably inform us around reserve capacity.
Right. Because even like you had mentioned, people who are, like, let's say they're being harmed, right? I forget the phrase.
Abuse,
neglect. I mean, you're going to want to, the government should be a safe, like that safety net type idea.
Yeah.
Are we in the parking lot where we can bring up other issues at this point?
The parking lot sign is on.
I see the slide.
I don't know, I looked at Jessica, are we in the parking
Well,
lot?
she's got it out.
She's driving there. She isn't the head of the.
You are fine, yes.
So our most recent meeting of this advisory council was in January, very shortly after the recent waiver amendments were approved on December 31st. Our next meeting is May 20th. At May 20th, I mean, I'm positive we're going to be talking about case management. We're going to be talking about, you know, the upcoming waiver amendments that may or may not be, they'll probably have been submitted, but not necessarily approved at that point. At no time have we really had an opportunity to talk about the implementation of the two waiver amendments that were approved for December 31st. And as you all know, I represent the Indiana Association of Behavior Consultants, which is hundreds of BCs across the state. We've worked very productively with you all to implement the changes. I don't think that we've been super negative about, you know, the caps or any of the, you know, I mean, we pushed back on some things, but we've tried to be a strong partner with you all. There have been some problems with the implementation of these waiver amendments, and it's disappointing that there haven't been solutions to some of the problems, and they kind of continue. And I'll just give you an example. You know, in December, we had numerous, you know, first of all, you all asked us to convert FBAs and encouraged us and said, convert these FBAs by January 1st, and you don't necessarily even have to use the template as long as they're compliant with our new requirements. Lots of work was put into that statewide. And then when budgets changed on December 31st or January 1st, many of those budgets were just simply trimmed retroactively. And you know, as an example, I have a very small agency with about 10 BCs. We had more denied claims in December than we had for the rest of 2025. We had more denied claims in December than we had for all of 2024 and the rest of 2025 combined. I talked to one agency that had over $10,000 in denied claims, and these were claims that were from approved budgets in the last waiver. I understand that nobody intended to, you know, mess with BCs. The intent doesn't really matter. The fact is that there are a whole lot of these denied budgets, and we've submitted JIRA tickets, and they either just sit there, they just don't get resolved. I mean, this is a real problem. We've tried very hard. We're trying to be good partners for waiver reset. And these are just, I don't quite understand the glacial pace of solving problems. And now, like with this meeting, we haven't even talked about these waivers. It's as if we're just moving on. I can tell you, you know, from a provider's perspective, we're playing by all the rules that you all set, and we're not really ready to move on. And we need a little bit more support in, you know, because we provide an important service for a lot of people across the state, and we're not trying to like get stuff that we, you know, we're not asking for anything new. We're not asking for anything more. Right. We're simply asking that you all honor the commitments you made in 2025. And even going forward, we have issues with how the service caps and how authorizations work.
So let's take some of that.
Okay.
So I know you and I have had some discussions and correspondence as well. I double checked this morning, any JIRA tickets that we had in January and February about the December billings are showing as having been resolved. So if we can work together and get a list of specifics, we can work through those.
Well, JIRA ticket might be resolved by saying, contact your case manager.
That's not what I mean.
Okay, but
I mean, the billing has been addressed.
Okay.
But we have to have those specifics to be able to.
Okay, not one single one of our JIRA tickets has a resolved issue in December. I'm just saying none.
If we can work together in your membership, I can get a list from your membership. We'll go that route.
Okay.
And we'll look at each
I mean,
one.
is it okay for a BC agency to submit a JIRA ticket? Because right now it's almost as if, no, we just have to add administrative burden to the case managers. That's literally what we're getting
It's
is,
not administrative burden to case managers. Let me be clear about that.
okay, well,
Or if it is, it's an acceptable amount of administrative burden. Now, case manager will have one. But
sorry, Laura.
it's not just for behavior support services, right? This is when there is a utilization issue, provider service provision issue that requires a JIRA ticket. We always have that go through the case manager, right?
Okay.
Because the case manager needs to know what was utilized and what's happening with the providers of services for the people they support. So
I do want to point out too, that the denied claims in December are not about the cap at 12.
I
Not
understand.
one single one of the ones that we had in my agency
Yes,
were
I
exceeding
understand.
12. That was not the issue. It was simply that the budgets got reassigned in January and then we didn't have any money left in December, even though we did the work.
I understand.
Okay.
So if we can work together and you can
Okay.
get a list from your membership, we won't wait on the JIRA tickets or
Okay.
whatever. I know we've gotten a significant number of JIRA tickets in March requesting to go back to December that we hadn't heard about before. So again, if we can get a comprehensive list, if we can work with you to get that from
Okay.
your membership, I think that can help us
Okay.
expeditiously address the individual cases.
Okay. Thank you.
And sorry, Laura.
You want to read what Becky said?
I can guess.
I'm just kidding.
Yeah, I can guess about that. But it is, again, case managers need to know. They need to know what's
No, I know about the utilization. I know a lot of it though is a lot of tech stuff. I know a lot of the PAs haven't been uploaded and they've had to redo a lot of those. That there've been a lot of similar situations where the essay hasn't been regenerated. And it's really not, it's not a case management issue, it's more of a system
A
issue.
system issue?
Yes.
Okay. If we can talk about that a little bit.
Sure.
so I'm not aware
Sure.
Of that. All right. There is a bit of a lag, right? Once a PCRSP is updated, that PA goes over to 4. Or the information for the PA goes over.
You are
to 4.
speaking a lot of Greek to a lot of.
I'm sorry. I'm sorry. I
Remind
stepped
you
into
that.
technical mode, so.
Gainwell is a whole other just.
Yeah.
They're talking about operating system.
Yeah. We don't want
I don't want that.
Modern life, right, is all the information on a person's individualized support plan is in an IT system. And that IT system has to talk to other state systems to generate the authorizations, if you will, for providers to bill against. So that's the Greek we were just talking about. Sorry.
This just reinforces my gratefulness for my case manager. So
Thank you.
Yeah.
We need
My
to hear that
daughters do.
lately. Thank you.
Yeah.
Yours too.
No questions?
Next meeting, May 20th. Cool. Here, I don't remember, we haven't seen, I don't even remember what room we're in right now.
We are.
Okay, so it'll be in this room, and hopefully we will have our new family member representative joining us at that time, so look forward to that. All right, thank you, everyone, see you
We'll
in.
also try to have Aaron Wright. review
Oh, yeah.
Some of their structures will be flushed out now.
Yeah, the Bureau of Better Aging Director.
Has become formal
Yeah.
in July, that legislature that passed, so we will be officially using it.
All right, thank you, everyone, see you in May.
It's true.
Jump. All right, I gotta roll.
It's so cool.
I know, I don't